It's my honor now to present Dr. Brentwood. Dr. Brentwood is a professor of laboratory medicine at the University of Southern California. He is the director as well of hematopathology at Children's Hospital in Los Angeles. His research is mainly focused on laboratory monitoring of clinical response in acute leukemia and biology of acute leukemia. Without further ado, I will leave the floor to Dr. Brentwood.
Thank you very much for that kind introduction, and it's a pleasure to be with you today to talk about minimal residual disease detection, both by flow cytometry and by molecular methods, very briefly. Could I have the next slide, please? So minimal residual disease detection, or now we call it measurable residual disease detection, is a technique that attempts to determine a patient's eventual prognosis based on testing early after therapy. We note that in patients with leukemia at the time of diagnosis, there are very large numbers of abnormal leukemic cells or blasts that circulate in the blood and within the bone marrow. And following initial therapy, the number of those leukemic cells hopefully will decrease in number. In some patients, this happens relatively rapidly, and it's relatively common for them to reach a point where one cannot detect the leukemic cells at any level, regardless of the technology that's used, as is shown on the left. In other patients, the response may be somewhat slower, and in some patients, they will retain the presence of residual leukemic cells for some time after therapy. And those patients we know have a somewhat higher incidence of relapse. And so the intent of this kind of testing is to observe both the initial kinetics of response to initial therapy, in other words, how rapidly the leukemic cells disappear from the blood and bone marrow, as well as the eventual nadir or lowest point at which they achieve remission, as an indication of the eventual potential outcome for these patients. Hopefully, by identification of residual disease early after therapy, one can intervene in those patients that appear to have a worse outcome because of the presence of residual disease and institute changes in therapy that then result in an eventual better outcome for those patients. Next, please. So there are a couple of basic ways in which we can detect residual disease. The first is looking at the presence of abnormalities in protein expression or antigenic abnormalities. Protein expression is governed by underlying a genetic process that's very tightly regulated, so that in patients that undergo mutations that eventually result in what we recognize as leukemia, it results in secondary alterations in protein expression as a reflection of the underlying genetic abnormalities. In a sense, the changes in protein expression integrate the effect of all the molecular abnormalities that have accumulated in a given cell. So by looking for the presence of these antigenic or protein-based abnormalities, we can identify and distinguish abnormal or leukemic cells from normal cells of similar type that are present in blood and bone marrow. And we'll talk about the way in which we do this in a little more detail. The other way to approach this problem is to look for the presence of molecular mutations. In other words, go right to the source where we know cancer originates based on the presence of specific molecular mutations. The problem, particularly in AML, is that there's no single target of which to design an assay. There's a wide range of different types of mutations that have been described, as you'll see a little bit later. And so single assays can't really be developed except for small subgroups of patients. Currently, those include patients with APL that have the 1517 translocation, patients with the 821 translocation, NPM1 mutation, etc. Hence, to date, most of these assays have been PCR-based assays looking at single genes. However, with the advent of next-generation sequencing or high-throughput sequencing technology that's capable of high-level multiplexed evaluation of genetic loci, we're able to design multiplexed assays that are capable of looking at multiple different targets at the same time. And those types of assays are now in validation for use as MRD measurements in AML. Next slide. Next, please. So if we talk a little bit more about flow cytometry, the basic method that we use for immunophenotyping by flow cytometry is based on a relatively simple principle, and that is that normal populations of cells express proteins or antigens in a consistent and reproducible pattern with maturation that's essentially invariant between individuals, regardless of their age, sex, race, etc. And so this serves as the reference point for understanding what normal maturation looks like and providing the ability to then identify populations of cells that deviate from normal maturation as a result of underlying genetic mutation. When this happens, the underlying patterns of abnormality in neoplastic cells can be quite varied. There can be increases or decreases in the expression of antigens normally expressed by a given cell type. There can be changes in the timing of expression, in other words, the relationship between antigens during the maturational process, so-called asynchronous maturational expression, where immature antigens are expressed on more mature populations of cells or vice versa. There can be, frankly, aberrant antigens expressed that would never be expressed by a given cell type, and this is great when that happens, but it's actually not the most frequent thing that happens. And for populations that are normally more variable or heterogeneous in the expression of a set of proteins, they may become much more homogeneous or uniform, reflecting the underlying clonal nature of the expansion in leukemia. So basically what we're looking for are populations of cells of a particular lineage at a particular maturational stage that look different from what we understand normal maturation to represent. Next slide, please. So what this implies is that one of the most important things is to understand what normal looks like so that we can then identify abnormal. And so the area where this was first employed and continues to be kind of the front runner in the application of MRD is in B cell neoplasms. So if we look at normal B cell maturation, we have a variety of different maturational stages across the top and a variety of different antigens that are commonly looked at in B cell malignancies on the left. And at each of these stages of maturation, we can map out the expression patterns of each of those antigens and develop a maturational map that describes the expression of those antigens along the maturational process for B cell maturation. So on the left, for immature early B cells, these express TDT in the nucleus, CD34 on the cell surface, a high level of CD10, along with the lineage-specific antigen CD19. As they move to the next stage of maturation, here called immature mid, TDT and CD34 are lost, CD10 expression declines, CD19 expression goes up, etc. And so by building an appropriate panel of antibody reagents, we can identify not only that these are B cells, but we can identify the maturational stage at which those B cells most closely correspond and simply ask the question, is the pattern of expression of all of these antigens meeting expectation? In other words, is it normal or not? Next, please. So this is an example of where we've operationalized such a panel of reagents. And so this is an 8-color flow cytometric experiment done many years ago and looking just at CD19 positive B cells. And what we can tell is that the relationships of the expression for each of these antigens is not random, that they cluster very tightly into discrete groups of cells along a maturational pathway. So that first early stage of B cell development I mentioned is in yellow. They express CD10 at a high level, CD45 at a low level, and as they mature to the next stage of maturation in light blue, CD10 expression goes down, CD45 expression goes up, etc. And so this represents our understanding of normal B cell development and serves as our reference point. Next. However, the other thing that we need to include in such panels of reagents are reagents which are commonly aberrantly expressed, or proteins that are commonly aberrantly expressed in a given type of leukemia. So it's not enough just to know what normal looks like. We need to have some idea as what could potentially be abnormal as well. So one can then survey a variety of different antigens that are of interest, as this group has, and they're indicated on the left, and catalog how frequently a given antigen is abnormal in this case, B lymphoblastic leukemia. What one quickly sees is that at the top, CD38 is very commonly abnormally expressed in B-ALL. So this would be a useful antigen potentially to include in panels for residual disease assessment, whereas antigens like CD21 or CD22, which are commonly expressed on B cells normally, are not abnormally expressed very commonly in B-ALL, and as a result, are probably not as useful, at least for the purpose of residual disease monitoring. So between mapping normal maturation with an appropriate panel of reagents and including reagents which we know are commonly abnormal for this disease, we can construct a panel of reagents. Next. So here's an example of such a panel of reagents that's been employed on this patient, which happens to be a medical student that developed B-ALL at our institution and was treated with bone marrow transplantation ultimately, and this is the bone marrow post-bone marrow transplant sample. So we're looking at CD19 positive B cells, and in the top row, second from the left, you can see CD10 versus CD20. Normal immature B cells are in light blue, normal mature B cells are in dark blue, and there's a population of cells in red, which is different from any of those normal populations. It expresses an abnormally high level of CD10, also co-expresses CD20 in a way that's not normal for B cells. CD58 on the next panel over is increased in intensity relative to normal immature B cells. CD38 in this patient is relatively normal on the bottom left, but CD45 on the bottom second from left is completely negative on the population of interest in red compared to normal immature B cells in light blue. And on the far right bottom, the population expresses CD34, but at a level that's slightly lower than that of the normal counterpart, which is seen just below it in light blue. So that population of cells in red has an overall immunophenotype that's most reminiscent of the first early stage of B cell development, or stage 1 hematogones, but exhibits important immunophenotypic differences that allow us to identify it as abnormal, even at relatively low levels, in this case at a level of 0.1%, which is not unusually low these days. Nevertheless, serves as a relatively straightforward way for B lineage neoplasms to identify the presence of residual disease. Next. So these are the panels of reagents which we have employed for over a decade in clinical trials with the Children's Oncology Group, where we serve as a central reference laboratory for MRD testing. On the top is a relatively simple 2-tube, 6-color assay that works very well for the identification of residual disease at early time points after therapy, such as end of induction. It wasn't designed to detect MRD in the presence of large numbers of normal B cell precursors later from therapy. Additional reagents could be incorporated into this, and there are versions of this that we've been testing. But for early identification of MRD, this is a very straightforward exercise now, and we've qualified over 30 laboratories around the world in order to do this type of testing for our clinical trials using that assay. In teen lineage ALL, this is a much rarer disease. We serve as the central reference laboratory for the studies for COG, but it's still a 2-tube assay in about a 9-color format that works very well for identifying residual disease in T-ALL on these clinical trials, using a very similar approach to what I've described, but with obviously a different set of antigens. Next. So what about AML? AML is a much more complex problem. The same principles can be employed, but we're talking now about a variety of different maturational stages for early progenitors as they mature in bone marrow. This is in part because the way we've defined AML is very heterogeneous and encompasses a wide variety of different entities, including leukemias that have a stem cell-like characteristic to them, as well as leukemias that have a more lineage-committed immunophenotype along many different lineages, including neutrophilic, monocytic, erythroid, plasmacytoid dendritic cell, etc. And so as a result, the panels are going to be inherently more complex, and the maturational patterns that one needs to understand are also likewise more complex. Also, we don't have simple lineage-associated antigens that we can use like we have in B or T lymphoblastic leukemia as a starting point. So in B-ALL, we often use CD19 or perhaps CD22 or 24 as B cell-associated antigens. In AML, because we're talking about cells that in some cases are even not committed to a lineage, they're hematopoietic stem cells, we need a different kind of a starting point or approach. So a common way to do this is to look at CD45, an antigen expressed on all white cells at varying levels, dependent on maturational stage, versus light scatter or side scatter. And here we have two representations of that, linear side scatter on the right, logarithmic side scatter on the left. And the progenitor populations of cells in this type of display lie in the gates or boxes that are indicated. So by focusing our attention in this area and excluding the events outside of this region, we can remove a large number of the relatively more mature cells that are very unlikely to represent leukemia and focus our attention on early stages of maturation within normal bone marrow and blood. Next. So this is an example then looking at that progenitor area on 45 side scatter using a variety of different antigens in a 10-color experiment that we did many years ago. We were the first to develop 10-color flow cytometry and implement this in a clinical laboratory. And we're essentially using the same approach as what I described for BALL, except now we're looking at different maturational stages with a different set of antigens. But the idea is the same, to map normal maturation and look for things that deviate from that as a marker of disease. So on the bottom row, third from the left, we have CD34 versus CD38, and what is circled are the hematopoietic stem cells having a level of expression of 34 that's relatively high, and CD38 that's relatively variable and low. That subset of cells is biologically very important in AML. Many AMLs contain subsets of cells that have similar types of immunophenotypes that are often referred to as the leukemic stem cell. And the normal counterpart has a well-defined immunophenotype that one can learn. Bottom row on the left, we have early erythroid differentiation with the increased expression of CD71, the transferrin receptor, so we can uniquely and early identify erythroid populations as they mature from those committed stem cells. Middle row on the far right, CD19 and CD34 can identify the early stages of B cell development and identify them in a specific way. And in the middle row on the left, CD13 and CD15 can be used to distinguish promyelocytes in green at the top, having a high level of 13 with co-expression of 15, and early monocytes below that having CD15 expression, but with a lower level of CD13. In essence, we're going through and mapping discrete stages of maturation along what is a continuum and learning what the immunophenotypes are as the cells move from hematopoietic stem cells to each of the major lineage-committed components. Next. So if we focused on a specific subset, such as normal CD34 positive progenitors, we could break them down into two very basic groups, the hematopoietic stem cells, which are colored orange or yellow here, and the lineage-committed progenitors that we've colored red. And so the stem cell population, you can see, has a very defined phenotype with the expression of 34 at a high level, 38 at a relatively lower level. CD117 or c-KIT is expressed, but at a level lower than that of the mature forms in red. CD13 is expressed, as is CD33, but at lower levels. HLA-DR is expressed at a lower level. CD123, the interleukin-3 receptor alpha chain, is expressed at a low level. And CD45, kind of paradoxically, is expressed at a slightly higher level than that of the lineage-committed progenitors in red. So this defines what normal hematopoietic stem cells look like. Next. But similar to what we did in BALL, we need to understand what is commonly abnormal in AML. And so surveys have been done of large numbers of antigens, in this case 1,400 patients with AML from the group in Germany, and cataloging the different kinds of abnormalities that are seen, which are of a much more complex nature, just because of the complexity of the populations we're dealing with. But in general, what's been found is that the large majority of patients, between 80 and 95% of patients, have on average 2 to 3 different kinds of immunophenotypic abnormalities or leukemia-associated immunophenotypes that can be seen in each patient. And so it suggests that it is possible to use this technology to identify abnormal populations for MRD detection. Next. As I alluded to, AML is a little bit unique in distinguishing it from B and T lineage leukemias, in that it has a hematopoietic stem cell-like component. And this is important to look at and monitor in these types of assays because they very commonly show immunophenotypic abnormality and are probably biologically important as a reservoir for eventual relapse. And so on the bottom, we have the normal pattern of expression on CD34 positive progenitors, looking at CD38 variably low leukemic stem cells. And normally these populations do not express antigens like CD7, 11B, 2, or 56, which are commonly seen in other lineages, such as NK cells, T cells, or early myelomonocytic forms. However, in AML, those same types of populations that express both CD34 and have variably lower CD38 on the top row can abnormally express these antigens, CD7 on the left, CD56 on the right, etc. And so it's useful to look at these antigens just practically in order to assess for residual disease, but also because these are potentially biologically relevant. Next. In addition to these types of antigens that have been described, there are a variety of other antigens which can also be looked at on stem cells as potential leukemic markers. And I apologize, it looks like the boxes here have become dissociated from the actual populations. But we've surveyed these, as have other groups, and you can see a variety of these different types of antigens and their expression patterns on myeloid stem cell neoplasms. And the take-home message is that there is a lot of variability. That almost all of these antigens show a subpopulation of AML or a stem cell disorder in which they're abnormally expressed, but they're not uniformly abnormally expressed on all patients. And so there's no magic bullet of a single antigen that one can use to assess all patients for residual disease all of the time. It's going to take, again, a much larger panel of reagents in order to do this work effectively. Next. So this is the panel that we constructed over 10 to 15 years ago and have validated extensively and published in the literature in many different trials for looking at AML MRD by flow cytometry, in which we continue to employ in clinical trials with some further modification. So the top row, labeled 1, is a combination that's designed to look at hematopoietic stem cells as they mature from these stem cells to each of the major lineages in marrow. It includes some of the more common myeloid-associated antigens like CD13, 33, and 117. It uses a backbone of CD45 to use in conjunction with side scatter to identify progenitors, and CD34 and 38 to allow identification of these early stages of development. The second tube is focused more on later stages of maturation from those committed progenitors to each of the major lineages of myelomonocytic maturation in particular, and includes antigens like CD64, CD123, and DR to identify specifically basophils, plasmacytoid dendritic cells, early monocytic differentiation, etc. And the third tube is focused on identifying the common aberrancies of CD56, 7, and 5 expression on these early progenitors in AML. So the panel focuses on identifying normal maturation, but also includes antigens that we know are commonly abnormal in AML. Next. And this is an example of what MRD and AML can look like. So this is a small subset of the overall data that we would look at in such an example, but this is a patient following induction chemotherapy. On the top left, we have CD34 and 38. We can see our normal pattern of maturation with the normal 34 positive progenitors in red that then mature and start expressing lineage-associated antigens with an intermediate level of CD38 kind of on the right. And there's a population of cells colored orange-yellow that has a higher level of CD34 than any of those stages and a slightly lower level of CD38. That is an abnormal population that shouldn't be present in this type of sample. On the top right, this population also expresses HLA-DR at a variably decreased level compared to normal, but with a lot of variation. On the bottom left, CD33 and 34 are overexpressed at a high level and different from normal. And on the bottom right, CD56 in particular is overexpressed to a high degree. It makes it relatively easy to identify this particular abnormal population of cells. So we've identified a discrete population of cells that has an immunophenotype different from any normal stage of maturation and consistent with the presence of residual leukemia. Now, this is an example used for illustration. Not all cases are as simple or straightforward as what I'm indicating here, but nevertheless serves as an illustration of how this approach works in AML, similar to what we saw in B lymphoblastic leukemia. Next. So let's look at a simple case just to see how this kind of works and emphasize a particular point. Here we have a 66-year-old male with a 1-month history of fatigue and pancytopenia. Next. And at diagnosis, we have the population in red, which represents the patient's leukemic population. So this patient has AML, the blasts or leukemic cells are in red. They have a low level of CD34 with low CD38, a high level of 117 with a little bit of CD15, and express 13 and 33. 1 or 2 weeks after therapy at day 16, we still have residual disease pictured in red. The population still abnormally expresses CD34 and CD38, although you can start to see normal stem cells in the background that have a little bit more CD38 and higher 34. But look at CD117. It's virtually absent on this population, which was very positive at the time of diagnosis. And there's more CD15 expression than was seen at diagnosis. Also notice 13 and 33. CD33 and 13 are now almost negative, very dimly expressed in comparison to the more robust expression seen at diagnosis. A month after therapy, the population of cells now is still present with normal maturation in the background, but those same phenotypic changes persist. So the point here is that there have been significant changes in the expression pattern of these antigens after therapy. And so one can't rely on the initial diagnostic immunophenotype to identify residual disease after therapy, even though it may be very useful to kind of point you in the right direction. Next. Next, please. Could I have the next slide, please? Hello? Next, please. Thank you. So if we look at these populations and simply ask the question, what is the least necessary information that we need to distinguish normal from abnormal cell populations? Is it the use of informative antibody combinations, knowing the pretreatment immunophenotype of the neoplastic cell, knowing normal patterns of maturational expression, or having an experienced interpreter? Well, A, C, and D are all necessary in order to perform this type of work. Otherwise, this approach doesn't work. It's B that really is the least important. We don't really need to know the pretreatment immunophenotype in order to identify the presence of abnormal neoplastic cells if we know what normal looks like and are using an informative antibody combination. Go to the next slide, please. And so if one looks at the overall workflow for MRD identification, based on this type of thinking, on a pretreatment sample, we like to run flow cytometry to identify the types of abnormalities that are present on the given patient's leukemic cells. These are often called the leukemia-associated immunophenotype, or LAIP. Post-therapy, we'll use the same panel of reagents to identify populations that are different from normal, but there are two basic schools of thought or workflows that are often used to do this. One of them is the so-called difference from normal approach, which is essentially what I've been advocating, which is that we identify discrete populations of cells defined by multiparametric gating or analysis, and we use the pretreatment immunophenotype as a starting point, but don't rely on it exclusively. The other approach that's been commonly used, particularly in Europe, is the so-called leukemia-associated immunophenotype, or LAIP approach, where a gate is defined on the pretreatment sample in a defined area where normally there are very few normal cells, but is present in the patient's leukemia. And then after therapy, the same panel is run and events are simply enumerated in that area as evidence of residual disease. What this approach assumes is that there is stability of the leukemic immunophenotype after therapy, and I've shown you one example where that's not the case, and as well, the background populations of cells are normal after therapy in comparison to resting bone marrow often, which also may not be the case. So as a result, people that use this approach advocate looking at multiple different immunophenotypic abnormalities at the same time, when possible, to mitigate these types of problems. The challenge is that you then end up with different types of populations being identified that have to be cross-correlated to determine what the actual level of MRD might be. And so often, just the highest level is what's selected. Now, there's an ability to harmonize these two approaches by allowing some flexibility in gating of the populations of cells. And for those of us working on consensus type of protocols for this purpose, that's the area that's being explored. Next. So here's an example from the literature showing in the middle row a leukemic immunophenotype on the far left at the time of diagnosis. And after therapy at progressive time points, the persistent presence of events still within that box, and the patient eventually relapses on the far right. On the bottom row, we also have, at the time of initial diagnosis, an abnormal immunophenotype that's been identified, the box drawn, and after therapy, the number of events in that area progressively decline after therapy, and the patient remains in remission. So this approach does work for a subset of patients, but there are the caveats that I've mentioned. Next. And one of those is shown here in a published paper, where we have on the left 4 dot plots in red the example of leukemic population that was identified. And you can see on the bottom row in second from the left that the population of cells in red really represents about half of a population of cells, part of which is also colored green. And so they're bisecting or dividing in half a single population of events and calling this an LAIP, an abnormal immunophenotype. On the right series of dot plots after therapy, that same analysis set of gates was used, and they identify residual disease. But notice in the top row far right, the population of events that's being identified does not look like a single population. It instead looks like the trail of normal distributions that happen to be falling into that area. These are probably just the outlying edges of normal distributions of cells and probably do not represent MRD. And so this approach doesn't really focus on identifying populations so much as just identifying events that fall within a given area or space that was defined on pretreatment samples. And as a result, is prone to problems both in terms of sensitivity and specificity for subsets of patients. Next.
Thank you, Dr. Wood. You have 1 minute remaining.
Thank you. And so if one looks at the frequency with which one sees these kinds of immunophenotypic changes, it's actually relatively common in AML. In fact, in this one early study using a somewhat simpler technology, they found that 91% of patients had some degree of immunophenotypic change after therapy that resulted in an inability to identify the leukemic population after therapy in somewhere between 2/3 and 90% of the cases. With more modern approaches, this has probably been reduced to some degree, but nevertheless emphasizes that there is a high degree of phenotypic change that occurs after therapy in AML. And so as a result, one can't rely exclusively on the pretreatment immunophenotype to identify populations of residual disease after therapy. Next. So case study number 2, we have a patient who had MDS who progressed over time to develop a frank AML with the accumulation of genetic mutations that included the NPM1 mutation. Next. And so pre-transplant, we evaluated this patient, a large leukemic population of cells in red, and an immunophenotype that's very characteristic of the NPM1 mutation, which was also found by next-generation sequencing at about 23%. Post-transplant, day 28, the marrow looks much more normal, with that population essentially not being detected by flow cytometry, but the NPM1 mutation was detected by molecular studies at a level of about 0.007%. So next. What does this mean? Is this patient likely to go into long-term remission? Are they going to relapse early after transplant, or perhaps immediately after transplant, or maybe they're already in relapse based on the NGS result? Next. Well, this is what happened to the patient. Day 56, that same population of cells now begins to make a reappearance by flow cytometry at a level of about 0.03%. The level seen by next-generation sequencing is also now increasing to 0.012%. By day 84, the population is expanded by both flow and next-generation sequencing. The patient is headed towards early relapse. Next slide.
Okay.
And so this is the data that we published looking at patients' MRD levels both before and after transplant and what the relationship might be to eventual outcome. And what one can see is that the only patients that did relatively well in this analysis were patients where there was no residual disease detected going into bone marrow transplant and that remained negative for residual disease after transplant. Everyone else did relatively poorly. Patients that had no evidence of MRD going into transplant, but who developed MRD after transplant were a horrible group. They're on the far left because they're basically relapsing through transplant. And if you detected MRD going into transplant, it didn't matter what happened after transplant, you had a horrible outcome. So the pre-transplant MRD was actually the most predictive of eventual outcome for patients with AML related to bone marrow transplantation. Just emphasizing that it's unclear exactly what transplantation is doing in this particular context, at least as employed here, but nevertheless, demonstrating that a patient is in remission and that it's sustained following therapy is very important in identifying the subset of patients that have a good clinical outcome. So with that, I would like to stop the presentation at this point.
Dr. Wood, for your presentation. I believe we're running out of time. Thank you, Dr. Wood. That was an excellent presentation. Thanks for coming here with us.